Hi everyone, my name is Rose Schmidt and I'm a PhD candidate at the University of Toronto. I want to thank the other panelists for allowing me to present this way today. Unfortunately, the original presenter, Dr. Carol Strike, is back home in Canada with COVID, and I am stuck in an apartment in Lisbon with COVID. So thanks very much. That's a picture of me. I'll be following along while this is played on Twitter, so if you do have any questions, just hit me up and or send me an email. So this presentation is called A Sea of Need. Safe Opioid Supply Service Providers' Accounts of Strategies Used to Prioritize Admissions. The objectives of the study that I'm talking about today was to explore the perspective of clients and service providers on safe supply programs, or SSPs. We looked at their experiences of enrolling into, receiving, and staying in the programs, the relationships between clients and clinicians, the perceived impact of these programs on the risk of overdose and other drug-related harms, the impact of the programs on HIV treatment and testing, the impact of COVID-19 on the programs themselves, and how, if at all, gender or racialized identity influenced the SSP experience. We looked, as I said, at the perspective of clients as well as service providers. And service providers included prescribers, so both physicians and nurse practitioners, as well as registered nurses and allied health professionals, who included community health workers, program administrators, case managers, and outreach workers, as well as pharmacists who prescribed or who dispensed safe supply. Specifically, my presentation today is looking at prescribers' challenges in setting admission priorities for these programs. The results presented in this presentation are part of a large qualitative study of interviews with 79 people. We spoke to 52 clients and 27 service providers. And I'm going to focus today on what we heard from service providers, mostly whom identified as white, 71%. 2/3 were women, and more than half were between 30 and 39 years old. We conducted all of the interviews by Zoom or phone, and we focused on the implementation and adaptation of safe supply programs using a consolidated framework for implementation research as a guide. We engaged in thematic analysis as a team and used a collaborative group coding approach. The programs included in this study were medicalized safe supply programs that were offered in primary care at community health centers, and this is the primary approach that is used in Ontario. However, this is just one end of the spectrum of safe supply. Across the country, there are different pilot projects that are looking at different drug options and different care models and delivery systems. So in Ontario, these programs, as I said, are delivered by community health centers primarily, but they were also deployed in COVID isolation hotels during the pandemic, and some individual service providers do prescribe in the community. Typically, what's offered in Ontario is a take-home dose of Dilaudid or hydromorphone, and for some, an observed in-pharmacy daily dose of Cadian or slow-released oral morphine, although not everyone wanted or needed the Cadian. The key piece is being prescribed a regulated and consistent supply that people had control over so that they can regulate their own use throughout the day. So when we looked at the prescribers' experiences and challenges in setting admission priorities, 8 key themes were identified. The initial admissions criteria that were developed for the SSPs focused on those most at risk of negative outcomes from unregulated opioids. They prioritized individuals with a history of unsuccessful opioid agonist treatment, as well as those with daily substance use, especially injection drug use, frequent and recent overdoses, and those living with complexities, so health issues, especially unmanaged HIV, those who were palliative, and those who were unstably housed. Some providers talked about trying to advance social justice through their admission priorities by focusing on engaging women, Black people, Indigenous people, and people of color, and members of the 2S LGBTQ+ communities. Providers described continually working to determine, refine, and implement these admission criteria. For some of these programs, they operated sort of on a point system. And they described how this wasn't a perfect system, and it was usually determined on a case-by-case basis through team decision-making and a collaborative process at each of the programs. Like on most things, the pandemic had an impact on the admission criteria. Data from across Canada shows a striking increase in opioid-related harms and death since the beginning of COVID. And this problematized the priorities of the programs. Initially, there was limited capacity on site to see patients during lockdown measures. There were restrictions on the number of people in waiting rooms, for examples. And COVID had really backed them up, as one of these providers said. The programs also had to deal with trying to support people who were started on safe supply elsewhere, so the COVID hotels, but then were in the community. There is enormous demand for these programs, and service providers describe struggling to meet the demands for admission. Basically, as one participant put it, there's a sea of need, but there's currently limited intake capacity. Most of these programs had very small staff complements, and they struggled to meet the demand, leading to teams going above and beyond without necessary supports and leaving them feeling exhausted, drained, and burned out. The programs had caps, numbers of enrollment, and could only manage so many clients. The Ontario model takes extra effort. They titrate folks, they provide ongoing, often weekly check-ins until they're stabilized, as well as providing primary care and wraparound care. So things like wound care, HIV testing, pap smears, but also mental health, housing, and social supports like assistance obtaining IDs. As a second participant here said, SSPs can't have a population level impact on overdose rates until we have more prescribers, allowing more participants to be on safer supply. The struggle to meet demand for admission led providers to try and control access in a variety of ways. First, they considered new intake procedures and criteria, and that they implemented, tested, and adapted over time. So since intake often was leading to sort of phones ringing nonstop and people calling in on behalf of themselves as well as their partners and children, the providers started reducing phone intake times, restricting to a particular day and at particular times. Some of the programs went a step further and stopped doing phone intakes at all, focusing instead on in-person outreach. Another way providers tried to manage the demand was by creating wait lists, but it was quickly identified that this was a problem. Wait lists grew very quickly and they were out of control. And it was also seen as an issue as the problem of overdose deaths is urgent. Wait lists became very difficult to manage and to find people again after too much time had elapsed. It was best to get someone into the program as soon as they could get an intake and come in, so same-day intake. Finally, providers tried to control access by restricting eligibility criteria with the most complex physical and mental health problems and those who are housing insecure, meaning those being brought into the program were the most marginalized, complex, and urgent clients. While focusing on the most complex, slowed admission, it also increased pressure on the severely stretched primary care resources. Those being brought into the program needed the additional care and supports. This created some frustrations from service providers, as well as concerns for both themselves and the well-being of clients. We've hit the ceiling on how many we can bring in until we start to stabilize the new intakes. The program's in a high acuity phase, where because of COVID and the suffering related to that, we brought in a lot of really complex patients. As I mentioned, there was limited staffing capacity at these programs. Some of the smaller programs only actually have 3 staff. And these staff went above and beyond, pushing themselves to do whatever they needed to meet the client's need. So they had an off-hour cell phone to call the pharmacy to ensure continuity of prescribing, accompanying clients to appointments, arranging transportation, working long hours, etc. But the number of people needing these programs and the fact that they still had to turn people away meant that the providers experienced moral distress and burnout. A number of the prescribers in these programs have taken medical leave. And one of the issues is that this is really a medical intervention for a number of social problems. So in conclusion, safer supply programs were originally conceived through a combination of evidence. So from addiction medicine, chronic pain management, trauma-informed care, as well as the practical experience of working with marginalized people who use drugs. These programs had to rapidly adapt to the changing reality of COVID and the accelerating overdoses. Providers used a range of strategies to screen for the highest acuity clients, those managing complex health issues who had not benefited from other medicine options and who were most likely to overdose. But this approach required significant effort and resources. Overall, we heard from providers that this work is challenging and complex, but it's also extremely impactful and rewarding. As one provider explained, "Nothing else I do in primary health gets this kind of response." Finally, providers felt that they were able to offer clients something that they needed or wanted, and that was making a change in their lives. It was saving their lives. Programs are still limited in what they can provide. As I said, they have severe capacity issues. But some of the programs have reallocated resources to greater nursing involvement and are increasing their enrollments. I would like to acknowledge the broader research team on this project. And I would also like to thank the study participants for sharing their experiences and expertise with us. Thank you so much for your time. If you do have any questions, please feel free to email me or hit me at Twitter. I'll be following along for the next few minutes to answer your questions. Thank you so much.